We found no evidence that patients were either benefited or harmed by those getting more blood compared to those getting less blood. There was a very large difference in the amount of blood used between the two arms of the trial, about a threefold higher use of blood in patients randomized to the liberal group. If this protocol was to be followed in similar patients, then you can count on reducing blood use by 2/3, which is very important. All the results trend to a slightly higher mortality in people who got more blood than less blood. Now, it's about a 1% or so difference between the two arms, so certainly not very high and certainly consistent with chance. That is, there was no statistical differences between it, but there certainly was no evidence that we were harming people in terms of mortality. We looked at things like infections and heart failure and length of stay and ICU stay and things like that, and once again, there was no evidence that we were harming anyone by using a restrictive transfusion approach, which resulted in the use of much, much less blood. The more traditional medical outcomes were looked at carefully, and the one that has the greatest interest, and I think one that maybe requires additional discussion, is our myocardial infarction outcome. This is the only finding in the trial which trended at all towards a potential benefit of a liberal transfusion. We have additional support from the NIH to look at mortality up to a year. It'll be 6 months to a year before we're ready to see what that shows. Asking the question is, well, we didn't show anything short term, but what about long term? Does it make any difference? So we'll be able to address that question, I think, very well. We're going to be looking at more in-depth evaluations of the functional measures where we have a lot more data. We're hoping to publish that sometime in the next year or two.